Hello friends, I'm Dr. Farheen, your OBGY faculty at Aakash PG Plus. Let's start the last and the final innings of INICET 3030. This is Oncology Special. So the time starts now. First question is, a 32-year-old female comes with dull aching pain and on USG it's found that she has a simple cyst which is of 5 centimeter. How are you going to manage her? So first of all, she's in the reproductive age group. The cyst is simple and it is of 5 centimeter. This is a very simple chart. So in the reproductive age group, it's a simple ovarian cyst. We need not do a CA 125. If the cyst is less than 5 centimeter, then we don't have to do anything. And if the cyst is between 5 to 7 centimeter, then annual ultrasound is recommended. If the cyst is more than 7 centimeter, then we have to evaluate the cyst further. We have to do MRI and then go ahead with laparoscopic ovarian cystectomy. Now, if it is a complex cyst which is on ultrasound, so we have to do hormonal test on the patient. We will do CA 125. We will calculate the risk of malignancy index which is based on the values of CA 125 and ultrasound levels. And if the woman is less than 40 years of age, then only we will go ahead with further hormone testing like LDH, AFP and HCG. Now, if it is a benign cyst and if it is persisting, then we will go ahead with surgery. If malignancy is suspected, then we will refer the patient to oncology department. Coming back to the question, the cyst here is 5 centimeter. So ideally we should not be doing anything, but that is not in the option. So we will go ahead with follow up after 2 to 3 months. Second question, clear cell carcinoma of ovary falls under which classification? So let's go through the classification. In benign, we have the functional cyst, which is a follicular cyst or a corpus luteal cyst or a hemorrhagic cyst. Now remember one mnemonic throughout for all the tumors, B, C, D, E. B is for Brenner's, C is for clear cell, D is your serous cyst adenoma and mucinous cyst adenoma, and E is your endometrioma. So this mnemonic stands true for epithelial tumors which are benign, for epithelial tumors which are malignant and borderline tumors. Okay. Now coming back to the specific tumors, in germ cell tumor you will see that all mature teratomas are benign. Okay. And immature teratoma will be malignant. Also, what are the other malignant tumors in germ cell? Dysgerminoma, endodermal sinus tumor, yolk sac tumor and embryonal carcinoma. Okay, but so that you don't get confused, just remember that germ cell tumor, mature teratomas are benign, rest all are malignant. Okay, now talking about the sex cord stromal tumors, fibroma and thecoma, they are benign, but malignant tumors are granulosa theca cell and Sertoli Leydig cell. Okay, and metastatic tumors that are malignant are Krukenberg, melanoma and carcinoid tumors. Now coming back to the question, clear cell carcinoma. So this is falling under the mnemonic B, C, D, E, right? So this is epithelial tumor. It is not a sex cord tumor. Sex cord tumor was thecoma fibroma, right? It is not a germ cell tumor and it is definitely not a functional tumor. Question number 3, identify the ovarian cancer as per the specimen. Now lots of options are here. Basically, they don't want you to remember how the tumor looks like. It is not possible to remember every tumor, the picture of it, and there can be a lot of pictures. But there is a very striking feature of teratomas that there is presence of hair, there is presence of bone, there can be presence of tooth also. So that is why they have given this image. The answer here will be mature cystic teratoma. However, let's go through the other options. Mucinous tumor, it is a cystic ovarian tumor. The tumor is very large in size. It is filled with mucin and it can fill the entire cavity. So this is a typical mucinous tumor appearance. Dysgerminoma is the most common malignant germ cell tumor and these malignancies occur in young women. It can also occur in pregnant women and the tumor is generally 1 centimeter in size. Mature teratoma, as we have already discussed, it is the second most common germ cell malignancy after germinoma. It is a gross solid tumor and there is presence of hair, tooth, bone, etc., cartilage. Krukenberg tumor is a metastatic cancer and 30 to 40% of metastatic cancers are because of Krukenberg. The primary site is in the stomach, colon or appendix and it has a typical appearance of signet ring adenocarcinoma and bosselated appearance. So coming back to the option, this is a mature cystic teratoma. Now question number 4, a 19-year-old girl presents with abdominal pain. She has ovarian dermoid. What is the procedure which is being done? So we can see that this is a circular image over here and under that we can see this is the uterus and this is the cyst. Okay. So this is a laparoscopic picture. Now we have to rule out amongst these options. So what is the treatment of choice? We have to remove the cyst. We don't have to remove the ovary, right? So the option will be laparoscopic ovarian cystectomy. It is not laparoscopic ovariectomy because we are not going to remove the ovary. It is not laparoscopic hysterectomy because we will not be removing the uterus. So therefore this is the answer of choice. Question number 5. What is true about cisplatin resistance and sensitivity? So first of all, what is cisplatin sensitivity? When the tumor has responded well to the cisplatin chemotherapy and there has been no relapse even after 6 months of chemotherapy. Okay. Now, other two confusing options are what is cisplatin resistance and what is a refractory case. Now, cisplatin resistance means that the patient has responded chemotherapy but the cancer has relapsed and it has relapsed within 6 months. Okay. And what is a refractory case? Refractory case means that the tumor was never sensitive to cisplatin. In fact, it never got resolved and it kept on progressing only. So, in refractory cases, patients who keep progressing besides being given chemotherapy. So remember that cisplatin resistance patient is getting fine but is relapsing within 6 months, but in refractory case the patient never got fine, the tumor never got cured. Okay. And how do you monitor the response to treatment? By CA 125 and CT scan. So resistance is recurrence within 6 months, this will be the option. Which of the following is not a risk factor for vulval carcinoma? So vulval carcinomas can be of two types, basaloid or warty or simple. Okay, simple or keratinizing. Now remember few points over here. Warty type. So wart is caused by what? Warts are caused by HPV infection. HPV infection is common in people who are sexually active. So younger people are more sexually active. It is also known as the usual type VIN. So remember YOUNG, younger people, usual type VIN. And over here it is seen in older people, so this is differentiated type VIN. Okay. Coming back to this point, it is also seen in people who are immunosuppressed, who smoke, and the lesion is always multifocal. It forms 40% of squamous cell carcinoma. Now talking about the differentiated or the simple variety, although it is a simple variety, but there is 60% chance of causing squamous cell carcinoma. It is seen in older patient. It is not related to HPV. So what is it related to? It is related to precancerous lesions of VIN, which can be lichen sclerosis or chronic inflammatory dermatosis, and as we have discussed earlier also, it is also known as differentiated type VIN. Coming back to the question, which is not a risk factor? HPV is a risk factor, yes. Smoking is a risk factor, yes. Lichen sclerosis leads to the differentiated type VIN. Vulval hematoma is not a risk factor. Vulval carcinoma is seen in which age group? So it is generally seen in an older age group, which is between 45 to 85 years. Identify the condition. So let's go through the options one by one. This is a typical presentation of a vulval carcinoma. We can see a fungating growth over here and the patient will present with severe itching. There will be dysuria, pain while passing urine. There can be bleeding also and mucus discharge from down below, and there will be skin pigmentation. If in the question it comes that the patient came with intractable itching, then vulval carcinoma should be the first thing which should come to your mind. What is vulval hematoma? So vulval hematoma is a collection of blood. It is generally seen when the episiotomy has not been stitched properly and the bleeder has been left behind. So it is a bluish discoloration because of the extravasated blood and it causes intense pain. Patient is not able to pass urine, and so this is how it looks like. What is a Bartholin cyst? Now Bartholin glands are located on the side of the vaginal opening and they secrete certain fluid. Because of some cause, the duct of the Bartholin gland can get blocked and it can lead to formation of a Bartholin cyst. Okay, so if the glands become obstructed, it can lead to a painless swelling Bartholin cyst. If the Bartholin cyst gets infected, it can form Bartholin abscess. Once the abscess has been formed, it becomes extremely tender, painful, patient will not be able to pass urine and patient will also have pain while having intercourse. So what is condyloma lata? Condyloma lata is seen in secondary syphilis. Patient will be VDRL positive and these are the typical elevated plaques. So coming back to the question, this is the case of a vulval carcinoma, as we can see a fungating mass over here. DS in pregnancy increases the risk of. So DS was a synthetic form of estrogen. It was given to women between 1940 to 1971 mainly as a treatment for preterm labor. It was later banned because it was seen that it caused a lot of teratogenicity. If the female child was exposed to it in the utero, she had increased chances of developing clear cell carcinoma of the lower genital tract or a T-shaped uterine cavity. And if the male child was exposed to it in utero, he had increased chances of having testicular or prostate cancer. However, there was no increased risk of breast cancer. So, DES in pregnancy increases the risk of clear cell vaginal cancer. The following instruments are used in which procedure? They repeated this question in another exam and they gave this image also. So basically this is how a pap smear is taken. Let's discuss the cervical screening guidelines. It was recently updated in April 2021. What is pap smear? It involves collection of cells from the cervix. The screening starts at 25 years of age. For all women 25 to 65 years of age, they should have HPV primary testing every 5 years. Now, if HPV testing is not present, then they can go with pap smear testing and HPV testing, which is known as co-testing every 5 years, or only pap testing alone, but then they will have to do it every 3 yearly. When to stop cervical cancer screening? If the patient is more than 65 years and she has had a regular screening in the past 10 years, she did not have any problem or any disease higher than CIN2 in the past 25 years, she has undergone total hysterectomy for a non-cancer cause. If the hysterectomy was done because of some suspicious cancer, then she has to continue with the screening. But if she had only supracervical hysterectomy done, it was not a total hysterectomy done and the cervix was left behind, then she will also need to continue with cervical screening. Now there are certain women who require frequent pap smear testing than 5 years. Who are they? First of all, those who have been exposed to DES at birth because they are at increased risk of carcinoma. Secondly, all immunocompromised patients, HIV, organ transplant, previous history of chemotherapy or corticosteroid use, or who have a history of smoking. What is the best time to take the pap smear? Mid-cycle between 10 to 14 days. What are the contraindications for pap smear? If the patient has active vaginal infection or presence of bleeding, because it is going to contaminate our screening test. What is the procedure? First of all, Cusco speculum is introduced inside the vagina to have a clear look at the cervix. Then this is the spatula which is used. First is the IS spatula, and this is used to take the sample from the ectocervix. This is the endocervical brush to take sample from the endocervix. This is a cervical broom which takes sample for liquid based cytology. Okay, so how is it done? The IS spatula is rotated at 360 degree for at least 2 to 3 times to take sample from the ectocervix. After the sample has been taken from the ectocervix, then we insert the endocervical brush inside the cervix and take sample from that. Now we have to take sample from outside to inside. So first ectocervix, then endocervix. Why is the endocervical sample not taken first? Because when you will remove the endocervical brush, the cells of the endocervix are going to stick to the ectocervix and the sample of the ectocervix can get contaminated and you might get false positive results. Okay. So for conventional cytology, at the end of it, a glass side is prepared. And what is the fixative used? 1:1 ratio of 95% ethanol and ether. This was also asked as an exam question. So what is the order of taking pap smear? First of all, 1342, you insert a vaginal wall retractor, you scrape the ectocervix, you prepare the smear and you fix the slide. Identify the procedure which is being done over here. So we can clearly see that a cone shaped sample has been taken over here. So this is nothing but cone biopsy, okay, or conization. Why is cone biopsy taken? Now cone biopsy, you can see over here that ectocervix is also coming and we forming a wedge so that a part of the endocervix also comes. So what are the indications for taking a cone biopsy? Limits of lesion that cannot be visualized on colposcopy. If the squamo-columnar junction is not visible clearly, when the endocervical curettage shows findings which are positive for CIN2 and 3, when there is lack of correlation between the pap smear, the colposcopic finding and the biopsy, or if the colposcopist is not able to rule out invasive cancer. Talking about other method options, so this is cervical cerclage. This is done in cases of preterm labor. Vaginal is the Shirodkar and the McDonald's method, and it can also be done abdominally by both laparoscopy or laparotomy. This is typically how a McDonald's cerclage is done. This is a large loop excision of the transformation zone. So what we are taking, we're just taking a biopsy of the ectocervix. This is a loop made of wire and through it electric current passes. As the electric current passes, we need to move the wire from left to right or right to left and it will scrape up a portion of the cervix and we'll be able to get the biopsy. So is it cervical biopsy? Yes, it is cervical biopsy, but more specifically, it is cervical cone biopsy. It is not cervical cerclage. It is not large excision of the transformation zone. A 46-year-old female has negative pap smear report and positive endocervical curettage. Okay. So her pap smear is not correlating with the biopsy report. What is the next step in management? So next step is conization. A 56-year-old postmenopausal woman has come with the growth on the cervix. Which instrument is used to take the biopsy? Okay. Now let's go through the options. This is the Alice forceps. Will you be able to take a biopsy with this? No. This is a punch biopsy forceps. Yes, we'll be able to take a biopsy with the punch biopsy forceps, and it has typical serrations over here so that it cuts through the tissue. But as we can see, it is very small in diameter and it is only for small visible growths, right? So we will use a scalpel. This is the BP handle and this is the scalpel, and we will scrape off this entire mass. We are sure that we have removed most of the mass and we will send it for biopsy. Okay. So since the surface area is larger, we will do it with Bart Parker handle with scalpel. Which of the following stain is used in HPV vaccine? So what are these options? These are nothing but HPV genome proteins. Okay. So HPV generates two types of proteins, early proteins and late proteins. There are 6 early proteins and there are 2 late proteins. So what do they do? The late protein L1 or L2 causes infection initiation and it is also known as the capsid protein. Okay. E1 and E2 is responsible for the replication of HPV in the host, and E6 and E7 is the most important and it leads to malignant transformation. So any vaccine which is also being prepared will target which protein? It will target E6 and E7, right? So E6 and E7 is the answer. A 59-year-old woman presents with the following condition. She has squamous cell carcinoma. What is the most likely genotype? Okay. So in this we need to remember what are the high risk HPV viruses. The high risk HPV virus most common is HPV 16. The most specific is HPV 18, followed by 31, 33, 45 and rest of all. But 16 and 18 are the one that you need to remember. So this HPV 16 and 18, they are responsible for all types of cancers. Low risk HPV types generally cause vaginal warts, anogenital warts and recurrent respiratory papillomatosis. This is important. Okay. So warts are caused by low risk HPV and high risk HPV generally cause cancer. Another trivia about HPV, the most common HPV present in a normal cytology or any invasive cancer is HPV 16. But what is the most specific? The most specific is HPV 18. Alright. Then HPV infections are usually transient and they tend to remain latent for many years. They can also resolve by 1 to 2 years. But if the patient is immunocompromised or smokes, then there can be malignant transformation of this HPV. So therefore, as it is mentioned that the patient is at risk of squamous cell carcinoma, so what is the most likely genotype? Most likely is HPV 18. Now what if HPV 16 would have been mentioned as the option? Then that would have been the option of choice because they are asking what is the most likely. But if they would have asked what is the most specific, then the answer remains HPV 18. Alright. Which of the following is not correct about HPV infection? It is epitheliotropic. It affects the epithelium. Yes, it affects the cervical epithelium. Viral proteins for malignant transformation are E6 and E7. Yes, they are mostly latent and they can get activated later on. They tend to resolve also by 1 to 2 years. Most specific for cervical cancer is HPV 16? No, it is HPV 18. A woman is undergoing endometrial biopsy and you are asked to hold the anterior lip of the cervix. What is the instrument shown over here? So the anterior lip of the cervix is always held by the valcellum. Okay. So what is the difference between valcellum and Alice forceps? Valcellum will always look as curved. This is curved so that when you're holding the anterior lip of the cervix, you have more space to negotiate. Okay. Howsoever, in the Alice forceps, it is straight. Okay, so the valcellum is longer and curved. A 55-year-old postmenopausal woman presents with vaginal bleeding. Endometrial thickness is 8 mm. What is the management of choice? Okay, another question is almost same. A 60-year-old presents with diabetes, hypertension, postmenopausal bleeding. What is the best investigation to evaluate her? Okay, so these are the risk factors of endometrial cancer, mostly obesity and diabetes. Okay, these are the most common risk factors. Other risk factors are tamoxifen, unopposed estrogen therapy, atypical endometrial hyperplasia. But if it is mentioned obesity, diabetes, also hypertension, then they are risk factors for endometrial cancer. Now, how do you evaluate this? Remember one basic thing, that the best method to evaluate endometrial cancer is a hysteroscopic directed biopsy. So hysteroscope is basically like a telescope which goes inside the uterus. You're able to see the entire uterine wall and you are able to take biopsy sample from any suspicious area. Okay, so hysteroscopic directed endometrial biopsy is the best step. If it is not present, then as it is you have to take sample from the endometrium. So any endometrium sampling will be the second step. Okay, pap smear is not done for evaluation of endometrial carcinoma and it is only done for cervical cancer screening. So coming back to the options, In this 55-year-old woman who presented vaginal bleeding, endometrial thickness was 8 mm. Next step is hysteroscopic guided endometrial biopsy. Okay. What is the cutoff in postmenopausal women? The endometrial thickness, it should be ideally less than 4 millimeter. Okay. Now again, how are you going to evaluate this patient? So ideally we should have evaluated by hysteroscopic directed endometrial biopsy. Since that is not in the option, we will go ahead with endometrial sampling. Pap smear is not done for evaluation, colposcopy again is not done for endometrial evaluation, and visual inspection of acetic acid is again done for cervical screening. Which of the following statement is false? So let's go through the solution first. How is the breast cancer screening done? It is done by mammogram, in younger patient by ultrasound, or by breast MRI, and by clinical breast examination. So for women between 40 to 49 years, generally it is offered that they should undergo clinical breast examination and mammography yearly. However, in women who are 50 to 77 years, it is recommended that they should be doing mammography and clinical breast examination yearly. Okay, we have already gone through cervical screening guideline once. So it begins at 25 years. For women between 25 to 65 years, primary HPV testing is done every 5 yearly. Core testing is also done every 5 yearly, but if only PAP test is being done alone, it has to be done 3 yearly. Now talking about colon cancer, it can be done by sigmoidoscopy or colonoscopy or CT. Okay. So coming back to the options, pap smear is a screening method for CA cervix, yes. Oral cancers are screened with visual inspection, yes. Mammograms done from the age of 40 years helps breast cancer, yes. Colonic cancers are screened with digital rectal examination, no. By sigmoidoscopy, colonoscopy or CT. Match the following. So basically you have to mug this up. Serous epithelial ovarian tumor CA125 is specific marker for that. For mucinous, it is CA199 and CEA. Endodermal or yolk sac tumor, it is alpha fetoprotein. Choriocarcinoma, beta HCG. Dysgerminoma, LDH and alkaline phosphatase. And granulosa cell tumor, inhibin. Okay. So primordial germ cell tumor are of two types, dysgerminoma and embryonal carcinoma. So this dysgerminoma is negative for both alpha fetoprotein and HCG, and it is positive for what? Dysgerminoma is positive for LDH and alkaline phosphatase, right? Now over here this is very simple. Embryonal carcinoma is positive for both alpha fetoprotein and HCG. We know that HCG is positive in choriocarcinoma, right? Alpha fetoprotein will be positive in yolk sac tumor. Just remember that. So for choriocarcinoma, HCG is positive, yolk sac or endodermal sinus tumor, alpha fetoprotein is positive. Now nothing is left. So teratomas will be negative for both alpha fetoprotein and HCG. Okay, so this is going to be our option. Call exna bodies, Samoma bodies and signet ring appearance. It is seen in what? So call exna or coffee bean nuclei is seen in granulosa cell tumor. Samoma bodies are typical of serous epithelial tumor. Signet ring appearance is seen in Krukenberg tumor. Other important points, Hobnail cell are seen in clear cell tumor and Rinke's crystal are seen in Hylas cell tumor. A 30-year-old female presents with 10 weeks history of amenorrhea, pain in abdomen. Ultrasound shows the following picture. So what is it? This is a typical snowstorm appearance. Okay. So this is a snowstorm appearance and this is seen in hydatidiform mold. Now the next question, a 25-year-old woman. Remember this is 25. She's had evacuation of molar pregnancy. So the previous pregnancy was molar. She is now complaining of breathlessness, cough, bleeding, which means there has been metastasis. Chest X-ray is also showing cannonball metastasis. So this has gone to the lung. Beta HCG level is 10 raised to power 3. Now they have been asking a lot of questions around the FIGO classification of gestation trophoblastic neoplasia. Score is given from 0 to 4. 8 factors are assessed and the mnemonic of which is SAM is bad. Okay. So S is your largest tumor size. A is your age in years. Then M is metastasis site and metastasis number. After that, I is interval months from the end of the index pregnancy to the start of the treatment. B is your beta HCG value. A is what was the antecedent pregnancy. Was it a molar pregnancy, abortion or previous live birth? Highest risk is when the patient had a previous live birth. And after that, the last is previous failed chemotherapy, if it was a single drug or if it was a multiple drug. Okay. If the FIGO classification score is less than 6, we will give patient injection methotrexate alternating with folinic acid for 1 week. After that, a 1 week rest, and we will do this till 6 weeks post normalization of beta HCG. If the FIGO classification risk is more than 7, then we will put the patient on IMACO regimen. What is the maximum risk of gestational trophoblastic neoplasia in case of prior? So the maximum risk of gestational trophoblastic, we can see that if she had a previous live birth and after that she has been diagnosed of gestational trophoblastic neoplasia, it carries the highest risk. and a previous molar pregnancy carries the lowest risk. Okay, so the answer here will be a previous term pregnancy. All are true about complete mole except. Okay, so first of all, what is gestational trophoblastic disease? It comprises of hydatidiform moles which can be complete or partial, invasive mole, choriocarcinoma or placental site trophoblastic tumor. Now, what is gestational trophoblastic neoplasia? When after the treatment of gestational trophoblastic disease, beta HCG continues to be high or it plateaus. Okay, now comparing complete and partial mole. So complete mole is diploid, partial mole is diploid. There are increased chances of carcinomatous changes in the complete mole. There are lesser chances of carcinomatous changes in the partial mole. Also, the fetal tissue is going to be absent in a complete mole. However, some tissue can be present in a partial mole. P57 immunostaining will be positive in partial mole, whereas negative in the complete mole. Okay. So, what is true except it is diploid, it has high risk of GTN, fetal tissue is absent. Okay. What is the best management for molar pregnancy? The best management is ultrasound guided suction and evacuation because the uterus is extremely friable, and if it is not done under ultrasound guidance, then the uterus can get perforated with the suction tube. Use of prostaglandins is not recommended for cervical ripening because it can lead to embolization of the trophoblastic cells. Therefore, it is contraindicated. About oxytocins, generally it is avoided, but if the patient is bleeding after evacuation, she is having PPH, then we can give oxytocins. After evacuation, what are you supposed to do? You're supposed to send the tissue to the lab to confirm the diagnosis, whether it's a molar pregnancy, in that also whether it's a complete or a partial mole, or is it a neoplasia. Okay. Second thing, if the patient is Rh negative, do not forget to give her anti-D injection. Third thing, we have to take a beta HCG value because basis that we are going to further follow up the patient, right? If the patient complains of bleeding continuously after MTP, it means there can be two things, retained product or it is a gestational trophoblastic neoplasia. So we have to repeat beta HCG values and we have to do a TVS scan. Now post evacuation surveillance by beta HCG is very important. If it is a complete mole, we will repeat beta HCG testing every 2 weekly. Now everywhere we do beta HCG testing 2 weekly, okay, and we will do this for 56 days. If after 56 days we see that the beta HCG has normalized, then we will do it every 2 weekly for further 6 months. If beta HCG has not normalized by 56 days, we will repeat it every 2 weekly till 6 months post normalization of beta HCG. Okay. For partial mole, it is simple. Beta HCG is done every 2 weekly till 2 samples come negative 4 weeks apart. This brings us to the end of IPL innings 30-30. I wish you all the very best for your preparation of INICET exam. Thank you.